Hi, I'm Vic Tapson. I'm in pulmonary critical care at Cedars-Sinai Medical Center in Los Angeles, and I see patients with pulmonary hypertension and pulmonary embolism. So I want to talk a bit about what evidence or guidelines are available for the treatment of PAH patients during the pandemic. And we have a lot of guidelines for PAH, as you well know. We've had ACCP guidelines, the great world guidelines. We met in Nice and published some data guidelines in 2019 about PAH. This is the meeting we have every 5 years. So these guidelines are still very, very useful during the pandemic. We're still trying to manage patients the same as we did before the pandemic. So keep in mind that guidelines for PAH before the pandemic still apply, but we can't do everything quite the way we wanted to. And so it's important to realize that the drugs we're using, the PDE5 inhibitors, the ERAs, the prostanoids, they're all the same as we use the same drugs we did before. It's a little more difficult, and it has been in the pandemic, to use inhaled therapy at times, like inhaled treprostinil. Good drug, but maybe more difficult to use. So we've converted some patients to oral therapy if they're in the hospital on nebulized therapy. In terms of guidelines, so same kind of guidelines. In the COVID era, though, there's some nice publications. There's some nice roundtable discussions offering some guidelines in the PAH journal called Advances in Pulmonary Hypertension. There's nice papers in pulmonary circulation suggesting certain things and the importance of monitoring patients. We've done a lot of monitoring by telemedicine. So to guide our therapy, we're doing this with telemedicine, examining patients carefully, adjusting therapy based on a good history and physical exam when we might not be able to get a cath so easily or an echo so easily. It's really important when a patient with COVID becomes unstable. You may have to pay very close attention to the differential diagnosis. Is it their PH? Is it worse? Is it COVID? Is it a pulmonary embolism? Is it a new infection of some kind? So these are all important considerations when you're treating patients with PAH. I want to emphasize a couple of points about vaccines. And this is something that the CDC has emphasized as a strong guideline, and that's getting a vaccine. And we've got 4 vaccines that have been most widely used: the Pfizer vaccine and Moderna vaccines. These are the 2 that you get 2 shots about a month apart. Messenger RNA vaccines, so very, very safe vaccines, very cool technology, and you can't get COVID from a vaccine like this. And then we've also got the J&J vaccine and the AstraZeneca vaccines. These vaccines are not mRNA vaccines, and there's been a little trouble with the AstraZeneca vaccine. As you've seen, it was stopped for the time being because of a blood clotting issue. The blood clotting issue occurred in about 6 out of 6 million people that got vaccinated. Now, the interesting thing is, as rare as this is, it was a specific sort of a phenotype. And I'm just mentioning this to keep in mind. I think we really need to emphasize to our patients they got to get vaccinated, and they're not at high risk for clots. These patients that got the AstraZeneca vaccine, they were women. And the age range was 18 to 48. They had this unusual sort of syndrome of cerebral sinus thrombosis. So it wasn't typical deep vein thrombosis, pulmonary embolism. And there was thrombocytopenia, platelet abnormality, platelet antibodies. So what is this? Well, all I think we can say is it's a rare syndrome being sorted out carefully right now. Didn't occur with Pfizer or Moderna vaccine. And so we need a little more information here. So our patients need to understand they're not going to get that vaccine right now, and that the Pfizer and Moderna vaccine has been very safe. J&J vaccine appears to be very safe. There's a little roadblock right now. It's being held up for a little bit right now, and we'll find out what happens. I suspect that'll be back. But J&J is being held up at the moment. So we'll have to look for more information in the future. So again, I think probably the best, most important information for our PH patients, besides the typical, social distancing and wearing masks, is get a vaccine. And we've got to be able to convince these folks because we've learned from earlier data published that patients with PH that get COVID don't do well. They often don't do well. We've had some get through it and do fine, but they need to understand the risk of COVID is much higher than the risk of an unusual, rare problem from a vaccine. These kind of problems are not common. They're exceedingly unusual, and it's far more likely someone will get COVID and die from it than get a vaccine and have a major problem from it. So let's get our patients vaccinated. Well, let me make some comments about kind of sum up PAH and COVID and the pandemic. First of all, our PH patients still need to be managed the same way as they have been before. We use the NICE guidelines, use our PH guidelines, use the therapies we use. Really sick people get parenteral therapy for COVID. Less sick patients may get the Ambition protocol, a PD5 inhibitor and a ERA. So that approach hasn't changed so much. We diurese the same. We use oxygen the same way. We try not to intubate patients. We try to use high flow if they come in and they have PAH. Whether they have COVID or not, we don't want to intubate them. If they have COVID, we try to avoid intubation. That positive pressure is not good for a PH patient. A few more kind of important kind of summary statements I'd like to make is that, again, patients should understand that vaccines are really important, and patient's chance of getting a problem from a vaccine is much, much, much lower than getting COVID and dying. So we really want our patients to get vaccinated, try to convince them that we can, talk to them about their fears, and sometimes it takes a little conversation, a lengthy conversation to get them to understand. It may be some worry about their pH, it may be some other worry about not thinking COVID is as bad as it is, but let's make sure we get people vaccinated. I think we're going to be ready for the next pandemic if there is one. I think we're going to be much better with telemedicine and monitoring patients at home. The future to me is telemedicine in many patients, at least for some intermediate and in between visits, maybe not for brand new patients and sick patients, but I think telemedicine is going to help us here a lot in the future. I've never cath patients once a year routinely. I don't think it's necessary. Some of you do. Certainly caths are really important as an initial diagnostic test, and in patients who either aren't doing well or you don't understand why they're doing well. But I think we've learned now we can get by with less diagnostic tests. If someone's doing well, they may not need that echo at 6 months. If they're really doing well, their weight is good, oxygenation's fine, they can walk well, their symptoms are minimal, maybe we can get away with a little bit less. So let's do some thinking about this, and I'm sure many of us will meet for a roundtable at some point and discuss these things further. Thanks very much.